Hello and welcome to the Neurotransmitters. Welcome back. I'm your host, Dr. Michael Kentris, and I'm happy to introduce our next guest today, Dr. Andy Webb, a neurocritical care clinical pharmacist from MGH Harvard. Andy, thank you so much for joining us today.
Yeah, thank you so much for the invitation again.
So, as so many of the people I'm fortunate enough to talk with, we met on Twitter/X, and I'm a big fan of the work you do there. A lot of educational content, and I particularly really enjoy your website with your deep dives on stuff. neurowiserx.com, and we'll probably talk more about that later. But I think a lot of people might have a more vague idea of like what pharmacy training looks like, and particularly when we get into the realm of clinical pharmacy. So I was hoping you could just, for those who might be less familiar, kind of throw a broad overview of what that looks like.
Yeah, absolutely. That's a great question. I think there's a lot of, not confusion, but people may not be aware of all the different kind of training programs and pathways that are out there for pharmacists. And so kind of the traditional path for a pharmacist starting out is it's very much so similar to medicine in that most pharmacists will do an undergraduate degree and then we'll go into a 4-year kind of professional clinical doctorate program. So the Doctor of Pharmacy degree program is a 4-year program. It's basically 3 years of didactics and then 1 year of clinical. So a little bit different there, where the focus is a lot on pharmacology, pharmacokinetics, also the kind of pathophysiology of the diseases, but really focusing on the pharmacotherapy. So a lot of the coursework that we do is kind of how drugs are used, the rationale for their use, kind of how you navigate selecting, monitoring, and kind of handling drug therapy. And then our final year, what we call like advanced pharmacy practice experiences or APPEs, is rotations out in the world. That could be at a hospital, it could be at a community pharmacy, it could be at a physician's office, or really anything in between. So a lot of our APPE experiences can be quite varied depending on where a pharmacist wants to go. And after you kind of complete your 4-year PharmD program, that's really an entry to practice degree where you could directly start working. So most pharmacists after graduating with the PharmD will start in a community pharmacy like a CVS, Walgreens, or an independent pharmacy dispensing medications. But clinical pharmacy is kind of its own subset of pharmacy practice. And so what you can do is actually do specialized residency training after you graduate from your PharmD. And so residency training for pharmacy has been around for a long time. It started in probably the last 20 years or so. And basically what that looks like is the first year of PGY1 residency training is basically just like a general residency. You can kind of think of it like a categorical intern year where you kind of see everything throughout the hospital. So you do internal medicine rotations, you do infectious diseases rotations, you can do an oncology rotation, a neurology rotation, an ICU rotation. And really the purpose of that first year of training is really to just give new grad pharmacists kind of like a broad overview of what clinical practice in a hospital, or some of the residency programs are based in the outpatient setting, like really what clinical practice looks like and how the pharmacist can kind of interface with patient care in that setting. And then after your PGY1 year, basically residents can choose to do a specialty year. And so they can select if they want to spend a PGY2 year, really focusing in on one individual clinical specialty. And so I completed my PharmD program at the University of Rhode Island. I actually did a bit of an accelerated program. So one of the options is doing like a 6-year track. So they're like 6-year med schools that kind of have a similar idea, where I did basically 2 years of undergrad and then 4 years of the PharmD. Then I did my general PGY1 at Mayo Clinic in Rochester. And then I actually selected critical care to be my specialty for PGY2. And so I went through the match again after just 1 year and did critical care training at Oregon Health and Science University out in Portland. I think throughout that entire time, as I was kind of going through my training, I always knew that I really liked neurology and that aspect of patient care. And so the fact that neurocritical care was kind of a facet of that I could go into was like perfect for me. And so I was lucky enough to land in the position that I am now. It's the neuro-ICU pharmacist at Mass Gen. But basically pharmacists can find themselves in those sorts of positions in all different sorts of specialties. And so really pharmacists are pretty well embedded into specialties like infectious diseases, oncology, critical care for sure. And I think neurology specifically is probably more of like a growing field within pharmacy. While I think neurocritical care is pretty well established within the field of clinical pharmacy, kind of neurology in general, there's definitely a pretty good number of us, but it's more of a growing specialty overall.
No, that's very interesting. I know at one of my previous practices, we would have sometimes, I think probably in the PGY1, we would have some pharmacy residents coming through like the epilepsy clinic and things like that, which obviously has its own unique challenges as far as pharmacology goes.
Yeah.
But speaking to that, so obviously critical care, a lot of subspecialized knowledge there, and then we niche that down even further to neurocritical care.
Totally.
So what are some of the unique challenges or kind of the aspects that drew you to that specifically, as far as like the neurologic aspect of pharmacologic care?
Yeah, so I think when I was in pharmacy school, I think I was kind of drawn to neurology and the medications used in epilepsy. There's 30 plus different seizure medications on the market. And so I loved the pharmacology of those agents, the complexity of the diseases, and also how much there was still left to learn about how we can kind of best take care of these diseases. So I think research is something else that I'm particularly interested in. And I love the fact that there was still so much development happening in how to really best take care and treat some of these hard to treat diseases. And so really the combination of the meds, the interesting diseases, the kind of opportunities for research and discovery drew me to neurology initially. And actually, interestingly, when I was in pharmacy school, I didn't really even know that critical care was a thing that I could do. And so my fourth year, my epi rotation, I took a Mickey rotation just because I wanted to kind of get experience in that. And I was like, I'm never going to do this again. I might as well. My initial interest in kind of complex pharmacology and that sort of decision-making, I found kind of a home in the ICU where there are these unstructured problems. There was collaborative decision-making. There was a lot of complexity, not only in just the patients that we were taking care of, but the medication therapy that were being prescribed to them. And then, so I did a Mickey rotation. And then as I was doing my rotations, there's obviously, of course, also a neuro-ICU at the hospital. So I went to my preceptor and I was like, I have this interest in neurology. Can I just spend a week in the neuro-ICU and kind of see what it's like? And so that's where I really found that that's what my calling was, so to speak, where I could still have that complex decision-making in an ICU setting, but also combine it for my interest in neurology. And I've never looked back.
No, that's really cool. And I know, at least from my own perspective, when we've had neuro-ICU pharmacists that we've been working with, or even more general, like critical care pharmacists, it's always been a real boon, at least from my perspective, where we're talking about dosing and interactions, because while I might be familiar with like the neurologic medications, sometimes there are more general things for like the heart or whatever that might escape my notice.
Absolutely.
And so it's always good to speak with someone who is more broadly familiar with the whole spectrum of interactions and the various pharmacodynamics and kinetics that go into all that decision making.
Yeah, exactly. I think that kind of collaborative team-based approach is, I think, one of the best parts about critical care, because everybody on the team, be that, the attending, the fellow, the resident, the pharmacist, the bedside nurse, PT, OT, speech, like we all have a contribution to patient care, and being able to kind of round out the care of the patient by really making sure that kind of all the T's are crossed and the I's are dotted, by really thinking through everything about the patient and the medication therapy that's prescribed to them, be that, their seizure meds or their secondary stroke prevention, but also like making sure we don't forget about, guideline directed therapy for heart failure, or those sorts of things that might not be the focus of their neurologic admission. And that's just like the great value of team-based care with the addition of a pharmacist to a team.
Absolutely. I couldn't agree more. Now, one thing that I always find, because where I'm at now, I work a lot more with medical critical care, and in particular, like with internal medicine residents and things like that, kind of at a more community teaching hospital. And I find that like one of the things I always have to hammer on about, probably to people's annoyance, is the importance of the blood-brain barrier in medication delivery. So I was wondering if you could speak a little bit to some of the unique challenges when we talk about drug considerations, both like in the neurology sphere as well as more broadly for other things. What are some unique challenges that you've come across, or that you find that you're repeatedly having to remind your clinical care teams about?
Yeah, I think that you make a great point of like considering what's going on with the patient with the medications that we choose is like huge. And so I think like the bread and butter stuff that we as pharmacists and I myself handle is kind of appropriately dosing medications based on organ function. So recognizing that a patient has a developing AKI or has suddenly like worsening synthetic hepatic function is obviously going to like greatly change how medications distribute and are eliminated throughout the body. And so I think probably one of the most common things that I do is just like optimizing and selecting dosing of medications, be that for, something that we can do therapeutic drug monitoring for, like valproate or phenytoin or antibiotics like vancomycin, or just kind of empirically selecting doses based on those individual patients' kind of organ function, like renal and hepatic function. I think other than that, I think also, like basically thinking about therapy for that patient, because sometimes it's, we have a patient who's on levetiracetam and they have like moderate to poor renal function, but they're in pretty bad status epilepticus. And I'm going to be like, I'm okay pushing the dose up a little bit higher here, even if, the textbook says that we should be lowering the dose. Sometimes my job is fighting not lowering doses. So I'm really making sure that we're optimizing the therapies that we have. I think that's also, I help a lot of my colleagues in other ICUs and other floors to use medications that they're also not super familiar with. So if there's a patient with a neurologic diagnosis on a surgery floor, for instance, one of the pharmacists may reach out to me and be like, hey, my team has a question on, topiramate dosing or some other dosing of some medication they may be less familiar with. And I'm also helpful in helping my colleagues through what considerations to have with these medications. Like the surgery team may be banging their head against the wall by this patient has an unexplained metabolic acidosis. And I get the question of like, oh, it's probably the topiramate. And so kind of considering some of those lesser known toxicities that patients, clinicians may be less familiar with medications they don't use very often. Education essentially is another large role of mine to helping make sure everyone can kind of use the medications they're using rationally and safely.
No, that's great. So yeah, as you were answering, I was coming to mind of a consult I had for someone in the ICU who I think her GFR was maybe 20 and she was like on 2 grams of cefepime BID.
A little bit confused.
If you can guess the reason for the consult, it was in fact altered mental status.
Yeah, I've seen this movie before. Yeah. That's like, related to that, kind of wrapping in the highest quality, most up-to-date evidence is another huge part of my role. So for instance, we had a patient who had a seizure overnight, not 100% sure what caused it. They were on cefepime. The dose was appropriate, but we have the ACORN trial. So I could point to evidence and say like, well, we have an alternative therapy that we could use. So we switched this patient to Zosyn because, it made sense for the infection that we're treating. And so helping my team kind of do the best evidence-based care is the other probably big thing that I do. I'm the guy who pulls my computer around to point at the most recent trial and like, look at this curve and here's why we can do this. And so that's another thing that I absolutely love is using evidence when we're taking care of patients and also teaching other people about what the evidence has to say about the decisions that we make.
No, that's great. And it just seems there's such a plethora of papers and trials on a daily and weekly basis. It's very challenging to keep up sometimes.
Oh, 100%. Like when the European Stroke Conference happened a couple of weeks ago, it was like every day I'm like, well, here's another practice-changing landmark trial that we have to consider.
I know. It's great, but it's also frustrating because it feels like everything I just learned last year is out of date now.
Exactly.
So, but such is the way of things, I suppose. But to that effect, like, yes, we have all these new things, sometimes telling us the thing we've been doing for maybe decades is wrong. And that there are still some of these older meds on the market. I've been thinking of in particular are valproic acid and phenytoin, fosphenytoin, all these things that are still like very much in the guidelines for specific situations. And in particular, I'm thinking of a deep dive you did onto the free versus total valproic acid trial that came out this last year. And I was wondering if you would indulge me and talk a little bit about the unique challenges when we're talking about like highly protein bound molecules and free versus total fractions, and how do we deal with that as things get more and more complicated?
Totally. Yeah. So I think you hit on a pet project or pet interest of mine. And I think that, as a pharmacist, pharmacokinetics is like one of the real bread and butter things that we bring to the table. And seizure meds have like some of the most complex and like frustrating head bang against the wall pharmacokinetics of all the medications that we have. So like phenytoin is like the perfect case example of, when I was in pharmacy school, we spent like 2 weeks on phenytoin PK alone, just because of learning about what Michaelis-Menten kinetics meant and how all the different drug interactions and protein binding interacts with things. And so I think that's also one of the things that really drew me to these sorts of medications is just how interesting and complex they kind of get around the body. And I think valproate is almost like an under-recognized, similarly complex, frustrating seizure medication in that perspective. And so as a trainee, I was kind of faced with some of these challenges if we had a patient on valproate, because your point, it's older, we have experience with it, it's in the guidelines, there's, quote unquote, good data for using valproate in various seizure types. On valproate, and they just weren't waking up. Their EEG was suggestive, that they're not seizing. There's nothing else obvious going on. And so my preceptor at the time, Caitlin Brown, was like, we should check a free level because this has complex protein binding. It was like off the charts. And so, we had this total level that was like 50 or 60. Like, this shouldn't be that big of a deal. Checked a free level. The free level was like 40 or 50. And you look at the reference range, that should be somewhere between like 5 and 15 to 5 to 20. But like, this is clearly abnormal. And it's something that I think a lot of teams just don't even think about, where they see the total valproate level and they're like, we're good to go. Like, this patient is in range, nothing to worry about. And by lowering the dose and significantly decreasing the patient's exposure, they woke up. And so it's kind of like a perfect seed to say, like, this is something that is clinically relevant, really does matter to the patients that we take care of, and is like very under recognized. Yeah. And so really, from some of the work that Caitlin Brown and her colleagues have done, got me additionally interested in really looking into this and exactly like why this happens. I think one of the other things that as a pharmacist I really like to bring to the team in terms of value is like, those deep dive, like in-depth understanding about exactly what these meds are and what they're doing. And there's so much about valproate and the other seizure medications that's just valproate is a bit unique in that it's just this little tiny kind of, fatty acid that just happens to hit all these different receptors and all these different ion channels, and just happens to kind of be this broad spectrum, very effective anti-seizure medication. But that sort of small fatty acid structure also means that it interacts with a whole bunch of other things you would not exactly expect. And to your point, the big thing that is important about it is it's binding to albumin. And when it's bound to albumin, it's not doing anything. When it's unbound to albumin, that's when it's pharmacologically active and able to have both its clinical effects and its toxicities. And not recognizing the difference between the total and the free can really lead clinicians astray in misinterpreting a level. And kind of what we found is that critically ill patients, for a myriad of reasons, have wildly altered protein binding and have wildly extreme exposures to free valproate levels out of proportion to what you might expect. And so kind of digging into the evidence has helped me, obviously hepatic dysfunction with changes in how much albumin patients actually have, but also things like unexpected drug interactions like aspirin and warfarin, propofol, intralipid from a TPN. All of these things will knock that fatty acid valproate off of its albumin protein binding site. It will increase patients' exposure. And there's actually some work that we're doing really looking at what the clinical consequences of that is. And basically what we found is that it really is the free level that is what's predictive of patients having side effects. And so we found basically that patients with really high free levels, even if their total level is fine, have more hepatotoxicity, they have lower platelets, they're likely more sedated, and you might check a total level and see that it's 50, and you're like, we're great. But if they're not waking up, it very well may be because their protein binding is totally off whack. And something like that aspect of really digging into the evidence and understanding how these meds are is one of the biggest roles I think a pharmacist can have, because those kind of like things you don't really think about that are just unique about a medication can really have pretty profound impacts on the kind of day-to-day individual care of one patient.
No, that's awesome. And it's, putting kind of our retrospectoscopes on, you kind of look back at some of these old papers from 40, 50 years ago.
Yeah.
And they're like, a non-dose relation, like with hepatic, or adepocode-induced encephalopathy or things like that. I'm like, well, maybe it is dose related. It's just not, something we weren't measuring decades ago.
And I think like with Depakote in particular, one of the most interesting things is, everybody knows that 50 to 100 or 50 to 125 is a good range. But when you talk about quote unquote good evidence, when you go back, the authors were essentially, they just guessed. They measured levels in a bunch of patients who had seizures who were on Depakote, and they noticed that patients whose levels were somewhere in the range of 50 to 100 tended not to seize as much. And they're like, this range is pretty convenient, so that's what we're going to go with. And that is effectively what the discussion of this paper is. There's no like empirical PK/PD analyses. It's just like, this seems sufficient. And that is kind of carried forward. And so there's definitely a lot more work for us to do to kind of update that.
Yeah. And that's, I remember when I was a PGY2 myself, and one of my epilepsy attendings asked me, like, it's like, so the valproate range, normal is 50 to 100, for phenytoin, it's 10 to 20. It's like, don't those seem awfully rounded off? It's like, there's the evidence is garbage.
Right. Yeah. Somebody made a good guess and they just kind of ran with it. And here we are 40 years later, just dealing with the consequences.
Yeah. So it is one of those things where it's like, it's kind of that old truism, at least in epilepsy. It's like, when's the person toxic? When they're having side effects? When are they therapeutic? When they're not having seizures?
Right. Yeah. Like I had an attending who's like, I don't really pay too much attention to phenytoin levels until they have nystagmus. It's like, well, I guess that's one way to do it.
I've heard that exact same thing before.
Yeah.
And that is, it's especially for those two drugs in particular. When I have round like students or residents rounding with me, one of my favorite, maybe not one of their favorite ones, is just to go around in a circle and name one side effect of valproic acid until we run out.
Yeah, and the circle can get quite large until you run out of side effects.
Right, and I think that's just so, to your point earlier, it's that we have to consider not just, it's easy to put our blinders on and think only about neurologic issues, but to think about the broader human body and what we might be causing.
Right.
Like one of the ones I run into more often, especially with those older meds, is like folks here with like AFib RVR who are on like an amio drip or something like that, and just like, well, we need to be a little bit careful here.
Right. Yeah. I mean, it's maybe this patient's platelet count is low because of the Depakote, or like their abdominal complaints might be pancreatitis from the Depakote. And people oftentimes forget about these like pretty rare, but can be quite concerning toxicities that aren't necessarily neurologic and in nature, because there are so many kind of off-target effects of particularly these older medications.
Yeah, I know there was that huge class action lawsuit over in the UK a few years back because people weren't being, or young women in particular, weren't being counseled on the teratogenic side effects, which obviously are super well known for decades, which I thought was just mind-boggling that wasn't being clearly communicated to like population at large.
Yeah, I think it's to the point where like prescribing of valproate to women in the UK is essentially restricted now, where there needs to be like clear documentation that other things have not worked and everyone is on the same page about what the pros and cons of this therapy is. So I think, to your point, it's easy to forget, like, it's an effective seizure med, we'll just start it for that reason. But there's a lot of things to consider beyond just seizure reduction. Yeah,
definitely very important. I remember I had a younger woman who, she was a immigrant from Central America, and she had epilepsy. I think if I remember correctly, it's been a few years. Sequelae like cysticercosis, and she'd failed like so many meds, and so I was adding just a little bit of Depakote. She was in her late 30s, and I said multiple times, both myself with my poor Spanish as well as via the official translator, like listen, you cannot get pregnant on this. And God help me, she showed up 3 months later.
Oh,
and she was pregnant. Fortunately or unfortunately, it seems she had not been taking her anti-seizure medication, so it ended up not being relevant in that case. But oh man,
but those cases stick with you for sure.
Yes, I was just like, oh my god. But yes, it's one of those things where sometimes it doesn't matter how much you harp on about it, the worst case still happens sometimes.
Totally.
As far as like we've talked a little bit about kind of your multidisciplinary role. What are your favorite things to treat in the neuro-ICU as a clinical pharmacist?
Yeah, so I think, related to the discussion we've been having, honestly, I think status is like by far and away the most favorite thing that I have to treat. It's funny because, status epilepticus can be deeply satisfying as a pharmacist, but can also be one of the most challenging and difficult diseases to take care of. And so obviously as the pharmacist in the neuro-ICU, I have an affinity for the disease state, which is largely exclusively treated with pharmacologic agents, excluding, VNSs and RNS and surgical therapies, right? And so I think the thing I love doing the most is just making the most of the medications that we have. And so in ensuring that, our Keppra is maxed out, our everything is maxed out. And then when the kind of standard things don't work, the creativity of like, what is the best next thing for this patient is like such a great experience to like choose a medication using some rationale, really thinking through the patient case as much as we can, and then seeing it work is like, has to be the most satisfying thing out there. It's kind of funny, in pharmacy school, when we learned about seizures and epilepsy and seizure medications, It was essentially like, here are the meds, here's what they do, here are the side effects. And there wasn't a lot of focus on like how you actually select an agent. And of like, really what does make the most sense for a patient of the legitimate 30 options that we have. It's been really satisfying to develop that kind of expertise to say like, well, for this patient, clobazam actually makes the most sense, or perampanel makes the most sense because they're ketamine responsive or something along those lines. And when it all works out, it's like phenomenal. It's like, to the point of the cases that stick out, there are so many cases of the patient who was burst suppressed for 3 days and really difficult to wean. And, the most recent one was like, we're all kind of wringing our hands as what to do next. And I was like, well, like the one thing we haven't tried is cannabidiol. And we start that and we're able to wean anesthesia. She wakes up 2 days later, she gets extubated. And like when those sorts of cases work out, it's just like such a satisfying experience as a pharmacist to be able to help optimize the perfect regimen to make sure the patient obviously isn't seizing, but also can kind of have a quality of life and get out of the hospital in a safe way. But I think the dark side of that is, it is very frustrating when things don't work out, which is one of the most challenging things about status, is when that patient really just doesn't seem to respond to everything or anything that we try. But the good thing, I guess, supposedly, is that is super inspiring to continue to work towards future therapies for what could work for those patients. And so I've been lucky enough to be involved in a clinical trial for refractory status epilepticus drug, ganaxolone, as kind of more an operational aspect of helping to screen patients and get patients enrolled in the study and actually get the study drug, and also involved in research, really seeing like, of the stuff that we have done, like what's working. And so really still being able to be involved in discovery about how to best take care of these patients is also the other thing that I get the most satisfaction out of.
Nice. Is that a new neurosteroid agent?
Yeah, exactly. And so it's in phase 3 trial right now. And so we don't know the results yet, but certainly very promising. It's the kind of drug where it's technically placebo controlled, but sometimes you feel like it's kind of hard to blind, So we're all, I think, all very excited to see what the final results of that trial are.
That'll be exciting. Yeah. I remember when they were doing I think it was pregnenolone. That 5 or 6 years ago at this point? Yeah, unfortunately not successful.
Which I think speaks to just how challenging it is to pick patients who might be eligible or benefit from these agents. So I think that the challenging thing about the RAISE trial is just how stringent the selection and inclusion criteria were. And so it was hard to find the right patient. And so we'll kind of see what the results are, but I think we're all very excited.
And I think to your earlier point, right, I'm a big advocate for the kind of the rational polypharmacy for status epilepticus or epilepsy management in general. Obviously, I'm biased since that's my background in particular. But one of the things that I think is so challenging, especially when we're talking about like drug selection, is like, what is the underlying etiology of the person's seizures? Just so heterogeneous in the population that it can be really challenging. Like, they've got an old stroke or an old traumatic brain injury, or maybe they have some sort of generalized epilepsy that's not well, distinguished. And there's just so many ways that it can shake out. It's very challenging sometimes.
100%. Yeah. And then you've got the patient with Norse who you are truly, wringing your hands about what to do next. And those patients, I mean, some of the regimens that I've, helped take care of patients on are truly unique when we're pulling out immunotherapies and we're starting ketogenic diets. And that's another big thing that I help with is how many milligrams of carbohydrate are in the perampanel tablet. So helping to tinker with all those things to maximize the success of those therapies. It can be a lot of fun. It's a lot of work, but it's a real, honor to be able to take care of those patients.
No, that's excellent. That is something, God, I haven't had to think about that since I was a fellow.
Headache to go through the list of 50 meds they're on and call manufacturers and be like, hey, is there more than 50 milligrams in this tablet? And they're like, why are you asking me this question?
Right.
But once you get the answer, it's a lot of fun to kind of figure all that out.
No, definitely. My wife's a dietitian. She's been involved with those conversations as well in the past. Yeah.
Carmen, who's our dietitian on the unit, is like phenomenal about going through all of those considerations. And we work very closely together to make sure everything's all tucked and tied in a bow before we start the keto diet.
Now, as far as like, if you wanted to say, like, why should someone who's considering, let's say they're in their undergrad pharmacy program, what would you say to those who might be intrigued by neurocritical care? What kind of experiences should they seek out?
Yeah, 100%. So I think the things to think about if you're thinking about going into neurocritical care is you really need to be the kind of person who likes collaborative decision-making and really thinking through an individual patient who makes the most sense, or, what therapy makes the most sense for that individual patient. You want to be the kind of person who likes thinking through evidence and applying that to a patient. And you have to be able to really like the complexity and a lot of the gray that is within and just inherent to neurology and neurocritical care. And so I think, if you're seeking for those opportunities, certainly if you're in your PharmD program, seeking out APPEs that are at like an academic center that has a neuro-ICU where you can work with a neurocritical care pharmacist who can introduce you to the team and kind of be part of that decision making. And also becoming involved in the Neurocritical Care Society, where we have a pretty active and well-established group of pharmacists who are quite integral to that society. So, for instance, Gretchen Brophy, who's a pharmacist at VCU, was the primary author on the NCS status guidelines that are now 12 years old, so getting a little dated, but regardless, just really highlighting the fact that pharmacists are pretty well embedded in NCS and are a really integral member of that team. And really the greatest thing about being a neurocritical care pharmacist is we really get to practice at the top of our knowledge. So, in pharmacy, sometimes we talk about practicing at the top of our license. So what we're legally able to do, be that independently manage medications or do therapeutic drug monitoring, all these sorts of things. But I think in the neuro-ICU, I really get to go beyond that because I get to really bring to the table, how do the drugs work? How do they interact with this individual patient's disease state? What's my understanding of the patient's pathophysiology? What complications we're handling right now? What's happening at the bedside? And everybody can kind of come together and make the best decision. For instance, we had a severe traumatic brain injury patient on the unit this week. And, I was at the bedside with the the fellow and the physician assistant thinking through like, what is the best next step on the ladder for this patient's ICP crisis? And it's a lot more complicated than just increase the propofol or just give 23%. It's really thinking through like, how do we understand what's going on inside that patient's skull and what do we have to do? And it's always a little odd when I'm the pharmacist and I'm like, I think this patient needs surgery. And so like thinking through all of the complexities there, I think as a pharmacist, being able to bring the medication side of things just really helps round out everybody's thinking through how we're going to best take care of this patient. And so, pharmacy students who are thinking about what clinical field they want to go into, that sort of fast-paced, complex decision-making with a lot of unknowns. Because I think one thing that, as a pharmacist, is really satisfying when I can point to a trial and be like, black and white, this is what the thing we need to do is. That's very rare in neurology to be able to say that.
It really is.
And so when I have learners, I think the thing that I have to really help them become comfortable with is like, there is no correct answer. So being able to be comfortable with what's our understanding of the data, the patient, what options we have available, and just navigating the best path forward. It's really hard, but it can be really satisfying when you kind of come to a conclusion, implement that plan, and kind of see it work out in front of your eyes.
That's excellent. And, to your point about the increased ICPs, yes, you're the pharmacist, but you're the person who knows, like, I don't think medication is going to work any further beyond where we've pushed it.
Right.
So I think that's still a very useful perspective to have on that front.
Talking with the neurosurgery residents, and they're like, well, you need to maximize medical therapy. And I'm like, I'm telling you, we have maximized medical therapy.
It is maximized. That is excellent. And for, let's say, internal medicine or neurology residents out there, or even nursing staff, if they want to learn more about neurocritical care pharmacy, pharmacology, what are some good resources that you would recommend?
Yeah, so I'll go back to NCS, where I think NCS and the group of neurocritical care pharmacists who are involved in NCS have done a really awesome job of producing good resources about neurocritical care pharmacotherapy. So there's the On-Call program, the PONS program, which is the pharmacotherapy of neurocritical care series. So there's lots of resources that relate to kind of the science and the knowledge of medication use therapy in neurocritical care. But additionally, there's a lot of resources about kind of like how to get in touch with neuro-ICU pharmacists if you want to network and get to know somebody in your area. And so I think that's probably the hub to kind of find pharmacists in this field. And particularly, if you are at an institution with a neuro-ICU that does not have a neurocritical care pharmacist, NCS also has a program called the ICP program, if I'm remembering it correctly, where it's basically what they'll do, and I'm now blanking on what the acronym actually stands for, but it's something about, something clinical pharmacist. Well, they'll basically send an experienced neuro-ICU pharmacist to an institution to help set up neurocritical care pharmacy services at your institution. So, for instance, if you're a hospital that's opening up a neuro-ICU for the first time, and the institution might be interested in having somebody come in, help establish pharmacy services, help write guidelines, establish the formulary, like figure out where you're going to keep your 23% vials or those sorts of things. NCS will actually sponsor an more experienced neuro-ICU pharmacist to go out to that institution, help mentor a pharmacist who might be establishing their practice site at that institution, and also really help the institution maximize the role of the pharmacist in that setting. So that could be, writing a guideline for ICP management or establishing workflows for status response. There's a good amount of data now that, having a pharmacist involved in these critical kind of experience or instances, be that, thrombolysis for stroke, response to seizures and status epilepticus. There's actually a recent paper that came out for anticoagulation reversal in ICH, direct involvement of a pharmacist in the care of those patients. Even if they weren't necessarily able to directly show benefits in mortality, they were able to show benefits in more surrogate outcomes like faster time to thrombolysis or faster time to anticoagulation reversal or more appropriate seizure medication dosing and faster time to first benzo. And when you put all of those things together, it's a pretty strong body of evidence that clearly definitively shows that involvement of a pharmacist does improve the outcomes of the patients that we take care of. So particularly for institutions who are either developing or looking to develop pharmacy services in this area, there's a lot of good resources to help support that and establish a good pharmacist presence in their unit.
Well, that is awesome information. I'm going to have to keep that in mind myself. I know we're in the process of expanding our neuro-ICU.
Yeah.
So good to know.
Yeah, definitely. It's an awesome resource. And there's a lot of good examples of, a new graduating pharmacy resident who's starting out in a new neuro-ICU. And it can be really intimidating as a new practitioner to step into a subspecialized ICU that doesn't have an established pharmacist already. And so there's a lot of institutional or organizational support to make sure that neuro-ICU itself can practice as best as possible. And that pharmacist is also supported to make sure that they can have the smoothest transition into practice possible.
Very cool. Very cool. Any final thoughts, things that you want to plug, projects that you're wanting to make the public aware of?
Yeah, definitely. So, I appreciate you kind of throwing out or shouting out my website. So, neurowiserx.com. I'll admit that I am probably not the most loyal poster because it turns out those posts are a lot of work to put together.
They look like it.
Yeah, but basically my hope is that I'll probably try to post a little bit more diligently in the future, but so there's certainly a lot of work to dig through every publication from 1960 on. But my goal is really to answer those sorts of questions in a way that brings up all the evidence that we have available. And certainly if people have questions that they want me to look into, I'm certainly open to those as well. I think the other thing to really just plug is that, pharmacists have a big role in neuro-ICU in particular, but really in any care where there is certainly a large value in having pharmacists round with your stroke teams or your general neurology teams or the epilepsy monitoring unit. And so kind of reaching out to your pharmacy departments at your individual institutions to see what resources are available. You might be surprised at what sort of value a pharmacist can add.
No, I couldn't agree more. I always considered it. We were just starting to get a pharmacist rounding on a regular neurology team where I was previously a few years ago, and it provided just this very subtle boost to everything.
Yeah.
It made everything a little easier.
Yeah, totally.
It's always great.
Yeah, absolutely.
But no, I couldn't agree more. It's always good to have more perspectives on the multidisciplinary side of things when rounding as a team.
Yeah, absolutely.
And if people want to find your work, they want to find where you are. I know we mentioned neurowiserx.com. Anywhere else they should check out for you? Yeah,
so I'm certainly busy on Twitter/X, whatever you want to call it. So my handle is AJWFarm. So I try to post relevant things to neurology, neurocritical care, critical care in general, be that the most recent evidence that I can find or my own opinion on kind of interesting things that have happened on the unit or in the field of neurology. And so I would say I'm fairly active there. So certainly excited to interact with everybody who is on that platform to kind of help us all. I think personally, I have learned a ton on Twitter and have tried to kind of return the favor. And I always love interacting with new people on that platform.
Awesome. No, I certainly appreciate your work on there as well. I've learned a lot myself.
Awesome. Yeah, likewise.
So Dr. Andy Webb, thank you again for coming on. I really appreciate your time today.
Yeah, awesome. Thank you again for the invitation. This was an awesome time. I really appreciate it.
And for anyone who wants to find the rest of our stuff, you can find our website, theneurotransmitters.com, where we have our old episodes listed. And you can also find me on Twitter/X at Dr. Kentris, DrKentris. Andy, thank you again so much. Really appreciate it.
Yeah, thank you again.